Next we have Professor Dr. Vijay. It was too good of you to come here in spite of your very busy schedule. And again, he was extremely simple to approach. I met him in the World Congress and requested him, sir, can you be with us? Immediately the reply came, yes. And more importantly, Dr. Ramesh called me and said, it's really brilliant to have a person like Dr. Vijay with you for this meeting. I had the opportunity to be with him. Unbelievable. He ran 39 operating theaters in Texas, Chicago. And an Indian running 39 OR in one of the busiest cancer unit speaks volumes about his quality and his ability and what he has achieved. So thank you so much for your time, and we really appreciate your presence here. Thanks a lot.
Thank you for those kind words, Dr. Balwankat. And again, it's, as I said in the Leadership Summit, it was truly humbling to be here and see the great work that's being done by all the awardees at the Leadership Summit, but also the leadership of the anesthesia fraternity in the country and the futuristic direction you're going and everything that's being done. It's been a great learning experience for me. My only sad part is I was not able to participate as much as I wanted because of various family reasons I'm having to deal with at this time. In any case, so Dr. Balwankat asked me to talk about long-term outcomes of the surgical patient and the role of the anesthesiologists. Just to build a little bit on what Dr. Arvind had said, when it comes to career development or research or mentoring, it's becoming more than a single-player act. So you always have to work along with others. If you translate that to the clinical arena, I would submit that anesthesia should no longer be in isolation, and everything we do should be in the context of healthcare delivery. Whether you're practicing obstetric anesthesia, then you're looking at long-term obstetric outcomes. If you're practicing in trauma, discharge from the hospital. If you're practicing in transplants, graft survival, and back to normal life. So wherever you're practicing, we have to work in the context of integration, multidisciplinary, and patient-focused outcomes. So if there is anything I want you to take away from this talk, is that we need to go beyond anesthesia outcomes, beyond failed intubations, beyond dental damage, beyond eye injuries. All those are important. We have to work on them. But if you look from the healthcare or the patient perspective, patient is coming to us not to just not have anesthesia, morbidity, but to go back to normal baseline status, and that's where our focus should be. So what I'm going to give a little background on the challenges of perioperative morbidity and mortality, but also the opportunities that lie for us as anesthesiologists and how we can improve those or build upon them. This is US data, and I don't doubt why this should be any different than any other practice. In fact, if anything, it could be worse in certain areas of the world. So perioperative mortality from all causes within 48 hours is 0.2%. But if you extend that from 48 hours to 30 days, it jumps tenfold higher, and it's 2%. So 2 out of every 100 people who have a surgery or a procedure in the US are dead in 30 days. Okay? Yes, it is amazing. If you extend this to 1 year, 1 year perioperative mortality is 5%. And if you are over 65 years of age, 1 year perioperative mortality is 10%. So 1 in 10 of all surgical patients over 65 years of age are dead at 1 year. Just think about this. And if 30-day postoperative mortality was considered a disease, it would be the 3rd leading cause of death in the US. Okay? So that's the challenge. but we have an opportunity where we can work together with our partners, whether it's obstetricians, or surgeons, or trauma docs, critical care physicians, and come up with strategies to improve that. So with that background, what I'm going to discuss in the next about 26 minutes is discuss the findings of Global Surgery 2030, which Dr. Morris had briefly mentioned at the Leadership Summit, and see how we can build the capacity to address the challenges of the report, discuss our role in improving long-term outcomes, so there may be a little overlap and a little more detail on enhanced recovery, what I had given an update yesterday, but also discuss how we at the system level can provide that value-based care. So if you haven't read this, I would strongly recommend. This is the Lancet Commission on Global Surgery, which was published in 2015. And what it shows is today, it's as good as when the report came out in 2015. 5 billion, that's 2/3 of the world's population, is without access to safe and affordable surgical and anesthetic care. And look how they added anesthesia. So even at the global level, people are recognizing the value which we provide to improve outcomes. Now it's upon us to live up to the challenge. And we have to be a part of this movement and initiative and partnership to improve long-term outcomes. 2015, still, there were 143 million additional surgical procedures which were needed to meet the needs of our patient, and this is more so in the low and middle income countries. If we don't address this, the loss in global economy and the productivity is going to be $21 trillion. But for us to meet this need, we need to invest $350 billion. So this is a huge problem. So we need to build that capacity, and for us to build that capacity, we need 2.2 million more providers who are well-trained and who can provide that safe surgical, anesthetic, and obstetric care. But all problems are not created equal. So that's one side of the story where we need to create that capacity to meet the needs and the demands. But even as of now, there is wide disparity. In certain parts of the world, we are still struggling with sanitation, access to basic medications. In certain parts of the world, particularly in the US, there is enormous rise in healthcare costs that if we continue down that path, for us, it's going to be a problem of sustainability. So there is disparities in basic medical needs or meeting the demands, and on the other side of the coin, it's for us to cut the costs and bring the costs down. So you may be thinking, how is this relevant to long-term outcomes? So if you look at all inpatient admissions in the US, 1/3 of all inpatients are for acute surgical care, and 50% of all healthcare costs are related to surgical care. And when I say surgical care, that includes anesthesiologists. So we not only have a role and a need to build the capacity, but we need to bring the healthcare costs. And while it's the story in the US, we are to the other extreme, I would submit to you that even in your own system, there is still plenty of opportunity to cut down the costs, particularly complications, medication errors, and wastes in the processes and the steps. And if you do that well, you're going to cut your waste by 20 to 30%, and then you would contribute to safe anesthetic and surgical care. So build capacity, cut down wastes, and treat preventable complications. So my interest in this went back to this publication in 2005 from Khoury and again from the Harvard system, where they've shown that there is a marked difference in the survival of patients who have complications and who don't have complications. Whether it's survival within the first 30 days, that first 30-day perioperative mortality which I have discussed, or even beyond, or even if you look at the first 24 hours. So if a patient has complications, there is a higher chance that that patient is not going to survive at whatever time frame we look into. And complications are expensive. But what is even more important is complications don't happen in isolation. Typically you will not have just one complication. If they're not addressed early, complications multiply, and as the number of complications increase, your morbidity and mortality increases, and so does your cost. So how do we go from where we are today to the future state where we look at long-term outcomes, particularly in terms of functional outcomes? There is a movement, particularly from the Australia and the Scandinavian countries, where they're looking at healthy days at home as one of the indicator of the success of the intervention, whatever it is. So people are moving away from intraoperative morbidity and mortality. Then we move to 30 days. We are looking at 1 year. People are looking at 5 years. But now people want to look at what is the value of what we did for the patients to come back to their baseline. So again, to expand on yesterday, everything we do depends obviously on patient factors. Not all patients are the same. They come with different comorbidity burdens, staging of disease, functional status. And based on this, then we have to work with our surgical colleagues and see what's the best approach to take care of that issue. Is it an open surgery? Is it minimally accessed surgery? Do we have the right tools? Do we have the right systems where it can be done safely? And once that's been decided, then the pillars of improving long-term outcomes are again minimizing symptom burden, minimizing complications and rapid rescue, and improving functional recovery. So I'm going to touch a little bit on these two factors, which I did not do yesterday. But the important thing is, it ain't anything fancy. You can do in any system you are. You don't need fancy monitors or technologies or equipment to accomplish this. All you have to do is stick to the basic principles. So the 4 things I'm going to touch upon is choosing wisely, optimal anesthetic plan, minimizing preventable complications, and then working within your system along with your surgical or obstetric partners. So choosing wisely was something that started with the American Board of Internal Medicine Foundation in 2012. And the reason they went down this path is, at least in the US, and again, I don't think that it's anything different in India, although it may not be to this extent. About a third of all diagnostic and imaging procedures do not add any value to what we are going to do during the perioperative period. 20% of all cardiac testing and the medications that the patients come with are unnecessary, irrelevant, and a waste. But more importantly, when we do unnecessary testing, imaging, or cardiac evaluation, we find some findings that may not be relevant to what we are doing, and then people go chasing that, and that typically adds cost, increases morbidity, and it sometimes also increases mortality. So after finding this, the ABM Foundation had approached all medical specialties in the US and have asked them to come up with 5 areas where we need to work to cut down this unnecessary waste, but also unnecessary morbidity and mortality by chasing these. And ABIM, again working with ASA, has come up with 5 points. Choosing wisely is also being done for pain management strategies within the anesthesia fraternity. So don't obtain baseline lab values for ASA 1 and 2 patients if they're coming for low-risk surgeries. Second, don't obtain baseline cardiac testing, which is stress echo or imaging, if the patient is asymptomatic, even if they have history, and if they're coming for low-risk procedures. Don't use PACs, pulmonary artery catheters, routinely in patients at low risk for hemodynamic complications, especially if you have somebody who's well-versed with TEE. But you may choose to use PA catheters in an appropriately needed patient. Don't administer packed red cells when the patient is no longer bleeding and hemodynamically stable, particularly if their hemoglobin is over 6. I'll touch upon that. There's a little bit of new information that goes against this recommendation. And don't routinely administer colloid for volume resuscitation without appropriate indications. Now, colloids may be needed, particularly in neonates and small children, but this is for adult patient population. So our goal is again to get the patient back on track. So from the preoperative phase, we focus on choosing wisely. Coming to the intraoperative phase, we have to minimize surgical stress. And when we talk about enhanced recovery, we talk about multimodal strategies, regional anesthetic techniques, all those are good. But the best way to minimize surgical stress is if we can do the same surgery safely and effectively by a minimally access approach. Granted, in certain patient population, they add certain challenges, but for the most part, robotic, laparoscopic surgery, purely from the surgical stress standpoint, are very beneficial and valuable. So in the US at least, there is a big move towards robotic surgeries. In our practice, about 85 to 90% of all prostates are done robotically. About 40 to 45% of all lobectomies in the lung are done robotic. Gynecologic procedures are head and neck. Endo-oral resections are all done robotic now. And it's amazing how soon the patients get back to where they need to be. And then proceed, building on that concept of minimizing surgical stress, how we can do that is to provide procedure-specific opioid-sparing analgesia strategies, minimize oxygen debt, and optimal anesthetic care. When I say opioid-sparing strategies, we need to design a strategy that works best for that patient. There's no, again, one-size-fits-all. In some patients, it may be the thoracic epidural. In some patients, it may be TAPs. In some patients, it may be just wound infiltrations. But the idea is, again, to have some form of local anesthetic-based afferent blockade, if we can, and do all other opioid adjuncts to minimize the amount of narcotics that are given. And the reason is, if you look at opioid-related adverse events, about 16% of all surgical patients have an opioid-related adverse event. About 30% of all medical-related errors are related to opioids. And this was published by T.J. Gann and all after reviewing the premier database in the US, which has data from 450 hospitals over millions of patients. And again, this also adds to the discussion of the narcotic and opioid abuse that's going on. So what most of the enhanced recovery programs, and particularly what we do in our practice, is in the holding area when the patient comes, if they don't have contraindications, we do age-appropriate dosing of tramadol extended release, oral acetaminophen, pregabalin or gabapentin, celecoxib, and scope patch. All of these are given orally when they show up at the holding area. Intraoperatively, we do one of these local anesthetic-based afferent blockade. It can range, as I've said, from wound infiltration, paravertebrals, TAPs, posterior intercostal nerve blocks for thoracic surgery, PECs for breast, epidurals or quadratus lumborum blocks, in addition to which patients get ketamine or nitrous, lidocaine infusions, IV acetaminophen, and dexmedetomidine, again as opioid-sparing strategies. Here, if you don't have Exparel, if you don't have dexmedetomidine, that's fine. Just try to design a regimen based on that principle of providing analgesia to the best ability you can while minimizing opioids, whatever medications are available to you which are appropriate for that patient. Minimizing oxygen debt. As I mentioned yesterday, when you talk about oxygen debt, so we're talking about global oxygen debt, you have to talk about fluids, you have to talk about maintaining your hemodynamics, and you have to talk about blood. And you cannot discuss any one of these in isolation without consideration to the others. So we'll briefly touch upon the key topics in each of these particular areas. So the ideal fluid administration strategy is for us to maintain normovolemia or optimal intravascular status. All of us know if you go under or hypovolemic, you're going to have splanchnic hypoperfusion, vital organ hypoperfusion, and organ damage. If you over-administer fluids, you're going to have tissue edema. So the question is then, how do you maintain patients in this euvolemic status? There was a lot of push for non-invasive cardiac output monitoring or PA catheters or CVP in the different time zones. But now it has been proven by large, randomized, multi-center studies that while non-invasive cardiac output monitoring may be helpful in high-risk patients, in routine patients coming for elective surgery, it does not add any value. So for us, we have the patients drink clear liquids until 2 hours prior to they arrive for surgery if there is any evidence of small bowel obstruction or intestinal obstruction. When they come into the operating room, we start fluids at about 3 mL per kilo per hour. And if needed, based on systolic pressure variation or stroke volume variation, we give fluid challenge of 200 cc's at a time to see if we can normalize. So by that strategy, and which has been adopted elsewhere, we've seemed to have a good balance of providing euvolemia without necessarily utilizing all the equipment that we need. But if you're fortunate enough to have that equipment, that surely helps you better understand the cardiorespiratory coupling and how do you interpret the hemodynamics when you don't have those available technologies. This is a publication recently, but last year. This is a graph showing the amount of fluids that were administered during major abdominal surgery in 2 major institutions in the US. So this is 2016, Vanderbilt and UC Irvine. These are 2 institutions which are one of the leaders in enhanced recovery. So as an example, if you see the amounts of fluids that were given for about 3-hour procedure, the amounts of fluid varied anywhere from 3 mL per kilo per hour to 40 mL per kilo per hour. And the vast majority of the fluids were about 12 mL per kilo per hour. That even in institutions where they've recognized the value of enhanced recovery, and these are academic institutions with leaders in fluid therapy, there is still a wide variation. So if you have so much wide variation, then having non-invasive cardiac output monitoring may be helpful. But if you stick to the basics, there's no evidence that goal-directed fluid therapy helps improve outcomes. The second important thing is hemodynamics. Again, this is a paper published early this year by Dan Sessler and group. They reviewed about 60,000 anesthetic records in their practice. All this is major non-cardiac abdominal surgery. And if you see the incidence of either acute kidney injury or myocardial injury compared to the baseline, which is a map of 70, as your patients spend more time being hypotensive, the number of events related to acute kidney injury or myocardial injury goes up. And that range is as significant as even a cumulative period of 5 minutes. So again, we don't pay that much attention to hypotension immediately after induction or before the incision takes place. But if you're in a practice like ours, where sometimes the time from induction to incision can be an hour, and if you are not careful, if your patient is hypotensive during that period, you cannot blow it away as the patient not being stimulated. This directly correlates to myocardial and kidney injury. This is the blood story. The Choosing Wisely campaign says you need not give blood if your patient is hemodynamically stable and if the hemoglobin is greater than 6. Again, this is a publication just 2 years ago from major cancer procedures. This was patients after having major abdominal surgery who have gone to the ICU, and in the ICU they were randomized to a liberal hemoglobin above 9 and a restrictive hemoglobin below 7. So they've transfused the patients based on these 2 protocols. And you can see the survival in the liberal group is much better than the survival in the restrictive group. So again, based on your patient population, along with your hemodynamics and volume, it's becoming clear that probably that 6 grams per cent, particularly after major resection, is not that safe. You may probably need to bump it up a little bit. So this is, again, a recent publication which highlights that anytime you have a myocardial injury, your 30-day mortality is going to go up. So this is a retrospective analysis of the vision patients. So this is a multi-center, multi-institutional study. Anytime in the postoperative period, your high-sensitive troponin levels go up, your 30-day mortality goes up. But see the adjusted hazard ratio here. I'm sorry you can't see because of the white. But anyway, if the troponin levels increase above 14, your adjusted hazard ratio for 30-day mortality is about 3.73, that's the second column. And if your troponin levels increase to more than 20 to 65, your adjusted hazard ratio is 23. But the important takeaway from this study is most of our patients in the postoperative period, they don't show typical signs of ischemia. So if you just follow your management based on if either the patient is complaining of chest pain or the patient has EKG abnormalities, we are missing at least 2/3 of the patients who are having silent ischemia, and these are the incidents which contribute to postoperative mortality. So maintaining tissue perfusion is very important. The other important thing is to avoid deep anesthesia. And there have been serious publications, particularly in the concept of triple low, which is mean arterial pressure less than 70, BIS less than 45, and a MAC less than 0.8. We are not entirely sure why this happens, but it's fair to say that if your patient is deeply anesthetized, and along with that, if your patient is hypotensive, the longer period your patient is hypotensive and is in a very deep state, there is a direct increase in mortality. So for every 15 minutes the patient spends in that deep state, along with hypotension, there is a 10% increase in both 30-day and 90-day mortality. Now you may say, we don't have this in our hospital system, and how do we know that the patient is deep or light? That's a tough situation. But what we did is, in patients who were not routinely being monitored with a BIS in our own practice, we just went and placed a BIS probe. And 80% of the time, our patient's BIS was less than 35. So without adequate monitoring, it's not about awareness, it's about depth of anesthesia. So depth of anesthesia directly correlates with peri-op mortality and morbidity. Second is protective lung ventilatory strategies. When I was in training, we used to ventilate patients with 10 mils per kilo and add a PEEP of 5. Now it's very clear that even in morbidly obese patients, if you don't have flow volume loops, if you cannot measure your compliance, it's perfectly fine to ventilate your patient with 6 mils per kilo of true body weight and then add PEEP as necessary. Reversal of neuromuscular blockade. This is another unappreciated issue that typically affects postoperative complications. 13% of all our patients have subclinical signs of inadequate neuromuscular blockade in the post-anesthesia recovery room. And this is furthermore if you're using long-acting drugs, particularly the steroidal agents, and if you're not adequately monitoring neuromuscular blockade in an objective manner. So what I want to just summarize for the intraoperative factors is avoiding deep anesthesia, minimizing hypotension, lung protective ventilatory strategies, adequate reversal of neuromuscular blockade. So to achieve these, you don't need any invasive technologies or new monitoring. And then use opioid sparing strategies providing that local anesthetic-based afferent blockade, whatever is appropriate for that patient, that will really help. Rapid rescue and avoiding long-term complications will extend this and provide that benefit in the long term. So if we do all this, then we can add value to whatever we are doing by minimizing treatment-related disability or harm and improving the quality of the patients, thereby adding value to what we provide for our patients. So for us at MD Anderson, what we are trying to do is push the needle even further by doing pre-optimization and brain health initiatives in the preoperative phase. Intraoperative phase, we are focusing on enhanced recovery. We are designing strategies to have rapid rescue teams to identify patients either with impending complications or complications, so we intervene early, and then we are designing a robust data collection and analysis strategies so we can improve our outcomes. So to summarize, choose wisely. Don't use unnecessary tests if not needed. They add cost and could potentially add morbidity. Choose an optimal anesthetic plan that works best for that patient, for that procedure. Do opioid-sparing analgesia strategies, minimize global oxygen debt, and minimize preventable complications. So by doing that, we can create an ambition-based platform wherein we can be a part of this discussion at the global level and be an important partner at the table when big decisions are being made about your hospital, where investment needs to be made and where we need to go to the future. I'm sorry I have to leave immediately after this talk, but if any one of you have any questions, please feel free to email me, and I typically respond to all my emails within 24 hours if I'm not traveling. So I'm going to be back in the US on Tuesday, so you can expect after that and response within 24 hours for any questions you may have. Thank you.
Thank you, sir. We want to